Dr. Gautam Khastigir, we are really very happy to have you with us, and the initiative that you have taken through this webinar, bringing us together, the Uttarakhand Society, the Chandigarh and the Bengal Society. So this is the time to tell us that yes, we have to be together. And with the new ART bill coming up, there will be many issues. The transition phase is not going to be easy. And we really hope and wish for you to come forward and be our face. So about you, a little about you, what I know, you are a recipient of Wellbeing Research Grant of RCOG London, published many research papers in infertility, hormonal therapy and endoscopic surgery in international journals, RCOG accreditation of subspecialty training in reproductive medicine and surgery, and level 2 endoscopic surgeries. You are the medical director of Birth and Advanced Fertility Center, head of gynecoscopy, providing hands-on training to 250 doctors in gynecological endoscopic surgeries, and organizing secretary of ISAR 2018, chair of ISAR Bengal, elected member of ISAR Executive Committee 2020-2022. Thank you, and I would welcome you, and please, you can start with your session. And it's a very interesting topic, our day-to-day challenge of managing unexplained infertility. Thank you.
Thank you very much, respected Nirmal Madam and respected Upendra Sir. Thanks for that very kind introduction. Now, I bring greetings from Kolkata. Can I share my screen, please? You can see my slides. Can you? Am I audible?
Yes, sir.
Yes, sir.
And you have the slide on the screen?
Yes, sir.
Okay. Thank you so much. So I bring greetings from Kolkata, which is known as a city of joy, and we're very proud to have many Nobel laureates and Oscar winner from there. And we are also very proud that the first IVF baby was born in Kolkata by Dr. Subhash Mukherjee. And that happened in the year 1978 when I joined the medical college. And all of you know that he had to go through a huge amount of humiliation because he was 20 years ahead of his time. So people didn't realize, suppose in 1978, if you tell someone you can have a telephone without a wire, like a mobile telephone, people will laugh at you. So when he said he has frozen the embryos and transferred in a natural cycle, people didn't believe. So he inspired me a lot. I've recently written a small book on history of IVF in India, which I have posted to all of you. So you'll be receiving it by post. Please let me know your feedback. And I'm really grateful that different societies are giving me the opportunity to share my experience. And today I'm going to talk to you or share my experience on unexplained infertility, which is basically something I'm very much interested because every day in the clinic, I face these patients' sort of unhappiness that we cannot tell them what is causing their infertility. So they're confused what treatment they're going to have. Now, I thank all of you for this opportunity, and you are thanking me, but I will just say this is an emotional statement. Although I'm in Kolkata, physically I'm in Kolkata, my heart is actually in northern India because my son has recently joined PGI Chandigarh as a M for postgraduate in obstetrics and gynecology. So I keep on visiting there, and whenever you need me, I will be with you for the rest of my life because that's a wonderful place I've been. I appeared in examination in Chandigarh, but never worked there. Now, causes of infertility, as you know, are multiple. When we were students, we were told 1/3 male, 1/3 female, and 1/3 unexplained. But now we are seeing the unexplained incidence is coming down. It is about 25%. Now, there has been a very interesting paper published recently in Human Reproduction showing that many centers are not doing that extensive investigations now. So we are doing concise infertility workup of just history taking, pelvic ultrasonography, and semen analysis. Because ultrasonography can tell us a lot about the uterus, about the ovary. If we do saline sonography, we can know about the fallopian tubes. And it is a one-stop. So patients can come, and of course, a blood test to look at the AMH, thyroid, and prolactin So you can do most of the investigations in one day, irrespective of which part of cycle they are. And that is very helpful for the patient. Basically, we get patients coming from all around the Eastern India and even from Bangladesh. So asking them to come again on the day 2 or day 5 of menstruation to FSH and LH is now history. But by doing less investigations, although it is less expensive, helpful for the patient, apparently there is more a diagnosis of unexplained infertility. So more we investigate, less will be the incidence of unexplained infertility. And it is also said the success rate of any treatment will be higher if you do more investigation. But we are in dilemma. We live in a country, but the cost is an issue. So we have to judiciously, like when you are doing drilling, you have to be judicious in terms of how many holes you make. Similarly, you have to be judicious, because when I came back from UK, many of my patients didn't have treatment under my care because I was doing too many investigations. And I learned from the receptionists that I have to actually break these investigations. Suppose there's a list of 10 investigations, you do not give all 10, maybe do 3 and then do some more. I'm talking about recurrent pregnancy loss. Now, as I've told you, it's extremely frustrating, not only for the infertile couple, but also for the doctors who are treating them, because you do not know the cause, so there is no effective treatment. But many authors are now saying we should change the name. We shouldn't call it unexplained infertility. Rather, we should call it undiagnosed infertility. And I said undiagnosed as yet. So we do not know the cause because we haven't done so many tests. Definitely there is a cause which we cannot find by ordinary test. Now, what are those causes? Why it is not undiagnosed? Because due to lack of specific test and sometimes false test results. If you do a hysterosalpingogram and if there is spasm, you often get cornual block. But then you do a laparoscopy, the tubes are open. So what do you call them? Tubal factor or unexplained? So sometimes they're unexplained, sometimes they're tubal factor because of the lack of specificity of the test and sometimes false test results. We are checking ovarian reserve by AMH and AFC, and many of the time we find AMH is good, but AFC not good, and vice versa. AFC good, AMH not good. So we are dependent on some tests on the lab and the accuracy of those, and AFC depending upon the accuracy of the ultrasound machine. If you have a very good ultrasound machine, fair enough. If it is not so good, the results are not accurate. And secondly, we cannot find the contributory factors. Now, what are the contributory factors? Could be peritubal adhesion, could be early endometriosis, which makes the environment hostile for the eggs and sperm. That won't be picked up by the ordinary test. It could be tubal transport problem. The tubal cilia are destroyed, or there is a bidirectional motility. Normally what happens is the fallopian tube, I say, is unidirection. It's a one-way traffic. The eggs are picked up on the fimbrial end and they are transported towards the cornual end. And embryo, once it's formed, from the ampullary side, it will go to the uterus. So it's a one-way traffic from lateral to the medial side. And the sperm is the only thing which has to swim other way around. It will come from the uterus to the fallopian tube. Now, there is no test to detect if there is ciliary damage or any problem with the tubal motility. Sometimes there is subtle problem with the ovarian reserve. So tests are normal, but the reserve is not very good. Some of the sperm issues are not picked up by the routine semen analysis. Like sometimes there is DNA fragmentation, which we didn't have this test earlier, but now we are finding, in spite of normal semen analysis, if there is, we don't do it as a routine. If there is history of unexplained infertility, you cannot explain, sometimes recurrent pregnancy loss, recurrent implantation failure, then we do it. And finally, endometrial receptivity or implantation failure. So I explained to my patient there has to be synchronization. When the embryo is best, on the same day, endometrium may not be best. Like I give this example sometime. Suppose you have a very good mango tree. Now your mango is ripe on Wednesday and your guest has come on a Sunday. So either you give unripe mango or overripe mango. So this is how we have to explain to our patients. But instead of finding the cause, let's give them some treatment which can overcome these problems. Now, the debate we have is whether to perform expensive and rare tests for all couple to improve the diagnostic accuracy, or let's go and treat these patients. So for pregnancy, as you all know, we need good embryo, we need good endometrium for a healthy pregnancy. On embryo, we can improve up to the blastocyst stage now. We can do PGD, we can do PGD, which will tell us the chromosomal status, PGT-A, if there is aneuploidy or not. And looking at the endometrium anatomically, the ultrasound by ultrasound endometrial thickness, and physiological function by endometrial receptivity array. Now, when you come to the management, often we are treating this patient empirically. What do we mean by empirically? That means, suppose she is ovulatory patient, she is ovulating, still we are giving her ovulation induction. If the sperm is normal, still we are doing IUI. So in that way, it's empirical, because what we have found, if patients have early endometriosis, mild tubal factor, mild male factor, immunological causes, then whatever treatment we give, like IUI, ovulation induction, IVF, they also work for unexplained infertility. So in that way, it may not be empirical, but we just don't know the cause. Now, what are the plan of therapy for a patient who has unexplained infertility? We can either do expectant management for 6 months to 1 year, or we can do aggressive therapy. What I mean by aggressive is active management of infertility, like active management of labor. Now, if the patient is less than 35 years and the duration of infertility is less than 3 years, so definitely we can wait for 3 to 6 months expected management. Expected management means just allowing the couple to have normal attempt during the fertile period. Tell them what is the fertile period. Tell them the sperm survives for 48 to 72 hours. So they should meet at least at the interval of 2 to 3 days between day 10 to day 20 of the cycle. Now, our patients are not always patients. So they want treatment quickly. They have been trying for 2 years or 1 year. And if you go them, okay, go back and try on your own. In good old days, during our studentship, our teachers used to say, and patients used to accept. But now that is not the scenario. So sometimes we have to treat our patients immediately, particularly if they are older and if the duration of infertility is longer. Now, what we have to remember with expectant therapy, that the natural conception rate with unexplained infertility is very low. The natural conception in a healthy couple is about 20 to 30% per month, whereas with unexplained infertility, it is about 2 to 4% maximum. So if patients wait for a year, the cumulative pregnancy rate is only 27%. But it has been statistically shown that if they wait for 3 years, it will go to 60%, for 5 years, 80%. But who is going to wait that long? And most frustrating thing is we are unable to predict which couple are going to get pregnant with the expected treatment and within what time frame. So if you waited for 3 years and after that you say, sorry, it didn't work, she's not going to be happy. Why we talk about expectant treatment? Because it has been reported that apparently we overtreat our patients. About 1/3 of the infertile couples who come to us, they are actually eligible for tailored expectant management. And it has been suggested that we should prevent couples from being exposed to unnecessary fertility therapy. We should evaluate and implement the strategies that will avoid this problem. So there's a question of ethics. But we should have uniformity. We should all speak in the same tune, same language. So institutions like ESAR, IFS, they can come together and they can make this type of protocol, which all of us are going to follow. Now, what is active management? Active management is treating patients for something which is more than the normal ovulation, more than bringing the sperms and eggs together and helping fertilization and helping implantation. And the NICE guideline came from UK, says that if 2 years of timed intercourse didn't work, then you go for IVF. Now, this is the belief of the Europeans and the British people. But ASRM, the Americans are recommending, no, don't go for IVF. You better go for IUI first for 3 cycles or maybe 6 cycles and then go for IVF. Now, we know if the woman is young, if the ovarian reserve is good, sometimes tubal flushing helps. All of us have realized that after doing a hysterosalpingogram, many patients do get pregnant. After doing a saline sonography, the tube is flushed, so the tubal patency is there. So instead of jumping straight away, maybe a laparoscopy, what Dr. Nutan said, laparoscopy, hysteroscopy is going to be helpful. And it is true that many a time we do laparoscopic ovarian drilling, which I'm looking forward to hear from my very good friend Sujata Kar. And she's another very good fertility as well as endoscopic surgeon, a very good combination. Now, what are the aim of our treatment? We want to improve by active management. We want to improve the monthly fecundity rate. And we can do that by improving the gamete quality, by increasing the gamete number, and we can facilitate the gamete interaction. And we have different things we can do, like superovulation or control ovarian hyperstimulation in addition with IUI. Why do we do superovulation? It will correct the subtle ovulatory disorder. It will increase the number of follicles and number of eggs released. It will increase the ovarian size. So ovary will come very close to the fembria. So egg pickup will be better. It will improve the tubal vascularity and enhance the ovum pickup mechanism. And while preparing the sperm, we can enhance the fertilizing capacity of the sperm. And we know by doing IUI, increased number of sperms will come to increased number of eggs and thereby improve fertilization and of course implantation. Question is when to treat, when to stop expectant treatment and when to do active treatment. As I told you, it depends upon the age of the patient, it depends upon the duration of infertility and how long and whether they were pregnant before or not. Patients who have secondary infertility, sometimes their prognosis is much better than those with primary infertility. Now, this algorithm summarizes and makes it easy for us. So if the patient is less than 35, between the age of 35 and 39, over the age of 40, we divide them into 3 groups. Less than 35, duration of infertility less than 3 years, we can continue expected management even up to 2 years, as long as the patients are happy. And then if it doesn't work, then we go for ovulation induction with HMG. And I'm saying HMG and not clomiphene or letrozole, and I explain to you why, for 6 cycles. And then if it doesn't work, go for IVF. If the duration of infertility is more than 3 years, even in this young individual, we can straight away go for HMG IUI followed by IVF. When the patient is more than 35 and the duration of infertility is more than 1 year, we still can do HMG stimulation IUI, but less number of cycles, maybe 3 cycles or 4 cycles, and then go for IVF. If the patient is more than 39, then irrespective of the duration, although it is said here that you can do, from this study I collected, you can do 1 or 2 cycles of HMG stimulated. In my opinion, the time is running out, so they should go for IVF straight away. Now, clomiphene citrate is a good medicine. For polycystic ovary, you can use. For PCO patient, for anovulatory patient, you can use. But in unexplained infertility, where the ovulation is taking place anyway, the success rate is very low. The success rate per cycle is 5%, which my good friend Shiladitya Bhattacharya, who is a professor in Aberdeen and now the editor-in-chief of Human Reproduction Open, has published a paper in Lancet saying that the live birth rate between clomiphene treatment and expected treatment over a period of 1 year is same. And you remember, you have to treat 40 patients of unexplained infertility with clomiphene to have 1 pregnancy. It's a number of cycles to treat. Now, letrozole is again very good for problem with ovulatory disorder and ovulation. It results in mono-follicullar recruitment and it avoids multiple pregnancy. It is very good when patients cannot afford FSH. So if you have a patient who cannot afford HMG or FSH, then you combine and reduce the cost of the treatment for patients who are undergoing IUI or IVF. Gonadotropin on its own, the pregnancy rate is still not that high. All I'm talking are about unexplained infertility, but not other types. But what happens is when we combine gonadotropin with IUI, the success rate usually goes up. So if we do IUI on its own without any stimulation, the success rate is again between 4 to 8% per cycle. So it has been said the role of IUI in an unstimulated cycle over timed intercourse is debatable. Again, Bhattacharya showed that if you tell the patient timed intercourse, whatever medicine they are taking is same with that of IUI. And clomiphene citrate is as effective as IUI alone. Gonadotropin stimulated cycle is actually better than IUI alone. So what we are trying to see, these individual clomiphene citrate, gonadotropin, IUI, they are not good enough. But as soon as you combine stimulation with gonadotropin stimulation with IUI, the results are very good. And this paper published in Lancet by Cynthia Farkas group from New Zealand showed that IUI with ovarian stimulation is safe and is effective treatment in women with unexplained infertility who didn't conceive naturally. So she's saying ovarian stimulation plus IUI is the treatment. And what we have found, the pregnancy rate will jump from 8% to 18% when a gonadotropin stimulation is added. But having said that, you cannot keep on treating these patients because the best success rate is in the first 3 cycles or maximum 4th cycle. But then the success rate will plateau. So question is, we should limit IUI maybe for 3 cycles and not continue up to 6 cycles. Another paper published in Lancet said that stimulated IUI intrauterine insemination is the treatment for unexplained infertility. But they have also commented that if the patient is elderly, so older than 39 years, then don't waste time, go straight away for IVF. And those patients who are very young, perhaps you don't do ovarian stimulation IUI, you should treat them expectant treatment, or to make the patient happy, you can prescribe them letrozole. Although you know that expectant management and letrozole or clomiphene success rate are same, but sometimes patients feel happy that you are offering them something rather than asking them to try on your own. Now, we believe in evidence-based medicine, and Cochrane Library has shown that intrauterine insemination for unexplained infertility has much higher cumulative birth rate compared to expected management, which I've been talking in last 10 minutes or so. But IUI in a natural cycle will result in higher cumulative live birth rate compared with timed intercourse. Treatment with IUI in a stimulated cycle may result in higher cumulative live birth rate in comparison to IUI in natural cycle. So the summary is, do IUI with stimulation. Now the question is IUI or IVF. Now apparently there is no difference in live birth rate between IUI and IVF with or without ovarian stimulation for patients who never had any treatment. If you have done IUI, it didn't work, then go to IVF is different proposition. But if you take a set of patients, one group you do IUI, other group you do IVF, and that's a very encouraging news for us, because in our country, majority patients cannot go for IVF, and IUI is a good treatment, at least for unexplained infertility, mild male factor, early endometriosis, things like that. Now, it has been said that in unexplained infertility, straight away going for IVF really doesn't give very good success rate. But another paper said that rather than expectant treatment, you do IVF. So expected treatment, not so good. IUI and IVF are basically similar. So again, I say you do IUI rather than IVF. Now this debate, first to do IUI or first to do IVF, the jury is still out. These are 4 eminent fertility experts. Half of them are saying pro-IUI and half of them are saying pro-IVF, even in the Western world, even in the university setup. So sometimes people think that if we are doing IUI, we are not giving the patient right treatment. That is not true. Now, in New Zealand, again, the Cynthia Furker group did a study looking whether to do IUI or IVF, and they found IUI is a low-cost, less invasive treatment to IVF in couples with unexplained infertility. And what they suggest, you do 4 cycles of ovarian stimulation IUI, followed by 1 or 2 IVF cycles, and that will have higher cumulative birth rate, lower cost per live birth, then straight away going for IVF, 2 cycles alone. Now, again, Cochrane database says that IVF is associated with higher live birth rate than expected management, and also then unstimulated IUI. So different authors are coming with the same message again and again and again, that don't do unstimulated IUI, do stimulated IUI. Now you have a group of patients who have been treated with clomiphene IUI, and then if you go for IVF, IVF will give better result. Now, however, in treatment-naive patient who never had any treatment before, there is no conclusive evidence of difference between IVF and IUI with gonadotropin, or IVF IUI with clomiphene. Finally, there is insufficient evidence of difference of live birth between the 4 treatments. So we have expected treatment, ovulation induction, just IUI, ovulation induction, and IUI and IVF ICSI. So altogether 5 treatments. So there is no difference to start with. But then eventually, when you have compared the expected management, it shows that whenever you are stimulating the ovary, there is a higher risk of multiple pregnancy. But when you're doing IVF, you avoid the risk of multiple pregnancy because you're transferring only one embryo, single blastocyst transfer, or maximum two. Whereas when you're doing IUI, suppose the 3 follicles have developed, you still go ahead, she can end up having a triplet. And also, all of you know that our pediatrician colleagues, they do not like infertility specialists because we are giving them lots of hard work, lots of extra work with premature delivery and problem with the neonates. But what is we are saying that moderate or severe OHSS are still there with IVF. So IVF, you can reduce the incidence of multiple pregnancy, but you cannot reduce the incidence of OHSS. Canadian Fertility and Andrology Society are saying that you should rather go for IVF early and not just continue doing IUI one cycle after another. And as I said, it will reduce the incidence of multiple pregnancy. And finally, this approach, we know it is invasive and it is costly. Now, as regards the cost effectiveness, we find that when you do IUI followed by IVF, it is much more expensive than going to IVF together. But this is not individual. This is when you're talking all the patients together. So those who are getting pregnant with IUI in the first cycle, they're very happy, or second cycle. But those who are not getting pregnant and going for IVF, their cost is higher. Those who are getting pregnant with the first IVF, they're very happy. Those who are requiring 3 treatment, again, the cost is much higher. And the same thing has been repeated in different papers in America and as well as in Europe. And these studies are saying, particularly in elderly patients, we should go straight away to IVF. Now, before ending, I will come to this very interesting situation we face in infertility. I'm sure those who are practicing infertility, you face this as well. You prepared a patient for IUI, and then there are too many follicles. So you have to convert it to IVF. So we call them low-cost IVF. So initially, we planned less amount of drug, but in spite of that, they hyperstimulated. And so we have that on one side and standard IVF on the other side. Let's see how things happen. The pregnancy rate is almost same, around 30%. But miscarriage rate is significantly lower if you stimulate these patients less, because the quality of egg is better. And there is less asynchronization between the embryo and the endometrium because the estrogen level is not that high. Take-home baby rates are very similar. But most importantly, it's more patient-friendly and it's less costly. So time has come for all of us to think whether we should do more mild stimulation, particularly in cases of unexplained infertility. So let's not be greedy. Let's not cook for the whole week. And then you realize that you have to go out to another city and the whole week cooking is wasted. So similarly, we are developing so many embryos and she's getting pregnant on the first attempt with twin, and the remaining embryos are there in the in the nitrogen tank for the rest of their lives. We have to discard them. So let's take small steps at a time. Let's think about one attempt at a time and explain to our patients that the cost is less, so they can have several attempts of treatment. Other issue we have discussed is as regards IVF, we should do standard IVF or we should do ICSI for unexplained infertility. Now, this paper published about 20 years back, they were saying that ICSI should be the treatment of choice for unexplained infertility because apparently there is less failed fertilization. But with the development of the embryology facilities, the embryology lab, the culture system, now this difference is not there. So we do not need to do ICSI straight away for all patients of unexplained infertility. Now, finally, there are some evidence-based treatment guidelines, and it is basically saying that whatever I have been talking to you repeatedly, I wouldn't go through this again and again. Perhaps you can look at this evidence-based treatment, which came in practice committee of the American Society of Reproductive Medicine. So in summary, we have to do expectant treatment. Then we have to go for ovulation induction, preferably with gonadotropin and IUI, and then we should go for IVF. And they have summarized that for most couples with unexplained infertility, the best initial therapy is typically 3 to 4 cycles of ovarian stimulation and IUI. You may do it with clomiphene and letrozole, and then followed by IVF, who couldn't get success with IUI. And there is a pressing need of some additional therapy to bridge the wide gap of effectiveness between ovarian stimulation, IUI, and oral medication, with oral medication and IVF. So ladies and gentlemen, I would leave with these take-home messages, which I practice, that in unexplained infertility, we need to look at the ovarian reserve much more closely: age, AMH, and AFC, 3 A's, sperm parameters, total motile sperm count, and DNA fragmentation index. And tubes, not just the patency matters. We need to know if there is peritubal adhesion or ciliary damage. And we can do very good 3-dimensional ultrasound scan. And I was listening to Narendra Malhotra yesterday, and he said that now we can easily identify peritubal adhesion if the ovaries are stuck, fallopian tubes are stuck, and eventually we will be able to identify damage of the fallopian tube cilia and understand more about the functional aspect of the fallopian tube. Now, as regards the right treatment, expectant management will have limited role only in good prognosis patient, but it has a low chance of success. And in my opinion, in our country, it is not that acceptable. Please have to give them something like clomiphene or letrozole so that they feel they are trying with something. The success rate is same irrespective of if this management. Before switching to IVF, cycles with ovarian stimulation, and then depending upon the ovarian reserve, duration of infertility, and the cost concern. And I thank you very much for your patient hearing. I will just say that why we are doing it together, because if we convert I to we, illness becomes wellness. So illness I and we becomes illness is converted to wellness. So let's all work together and help our patients to get a better treatment so that the problem of infertility is almost gone forever. So there is no question of infertility, which is a taboo in India, as you can understand, a big social problem. I sincerely thank you all for your support and for your patient hearing. I'll be more than happy to answer any queries if there are any. And I would love to know your opinion. Please tell me what you do for unexplained infertility. If it is different, we are definitely happy to go ahead and try your method. Thank you.